Good afternoon. My name is Dr. Hussain. I'm one of the medical directors at Skin Clinics London, and I'm also an honorary lecturer at Queen Mary University of London. Today, I wanted to talk to you about hyaluronidase, and in particular, its use in the management of complications of dermal fillers. Effectively, it's a little gift for you, today's tutorial. I often get asked about management of complications of dermal fillers, how to use hyaluronidase, how to make it up, what concentrations to use, how to inject it, where to inject it, and the techniques to inject it. So all these questions will be answered today in this tutorial, and effectively I would, if I were you, record it, keep it with you, accessible on your phones at all times, and I will be there in your pocket to advise you when you need me if anything goes wrong. So let us talk a little bit about hyaluronidase, the enzyme, which is a prescription-only medicine in the UK. There are three sources of hyaluronidase. Effectively, two of them are particularly tasty. The first source is sheep or cow testicular hyaluronidase, or ovine or bovine testicular hyaluronidase. Secondly, we have hyaluronidase that's sourced from hookworm and leech salivary glands. And thirdly, what I might prefer to have used myself perhaps, we have human recombinant hyaluronidase. So, I listed three sources of hyaluronidase. In the UK we have effectively ovine testicular hyaluronidase. In the US, human recombinant hyaluronidase is available. Now, the differences between the two are effectively boiling down to the fact that in animal-sourced hyaluronidase, such as the ones we have available in the UK, the likelihood of having extraneous protein material in the actual hyaluronidase is higher, even though it's purified, and hence it is a little bit more immunogenic, meaning that the likelihood of a type 1 hypersensitivity reaction to the product, or even delayed hypersensitivity reactions to the product, are higher. This is why human recombinant hyaluronidase was developed, to try and minimize the likelihood of this type of problem. However, it's not yet widely available in the UK, so I won't be focusing on Hyalase, the product that I'm talking about, the human recombinant hyaluronidase, in this tutorial. Hyaluronidase works by catalyzing the breakdown of hyaluronic acid, and it does so by breaking down the glycosidic bonds within hyaluronic acid. Effectively, this depolymerizes the hyaluronic acid filler gel. Effectively, it starts to work as soon as in contact with the substrate. So the minute you inject hyaluronidase, it starts to work. The time of action is from minutes to hours. Effectively, the thing that affects how long the breakdown takes is the concentration of hyaluronic acid that you're dissolving, the amount of cross-linked hyaluronic acid within the gel that you've injected, the amount of hyaluronidase you've injected, or the concentration you've injected, and the volume of actual injected gel. Hyaluronidase diffuses rapidly through the tissues, and one of the benefits of hyaluronidase is that it transfers or diffuses across connective tissue. And thanks to this property, even if injected outside a vessel, for example, it can still dissolve filler within a vessel, which makes it a very, very effective tool in the treatment of filler complications. An interesting feature of hyaluronidase is that if injected intravenously or into a vessel effectively, it is in many mammals progressively inactivated. Now, this throws up an interesting question, and that question is, does direct intra-arterial injection render hyaluronidase useless? In which case, if we try and inject it directly into a blood vessel which is blocked, are we in fact inactivating the hyaluronidase? This is something I'm going to explore a little bit further in section 2 of the tutorial, so we'll wait for that answer to be delivered completely. Contraindications to hyaluronidase use are as follows. It should not be used if anyone has an allergy to hyaluronidase or any of the components of the actual medicine itself. The second thing to bear in mind is if you inject it into an area that is inflamed or potentially infected, this can increase the spread of infection. So if infection is suspected, one must use antibiotic cover if they are considering the use of hyaluronidase, or if it's not necessarily an urgency, then treat the infection before hyaluronidase is used. In order to make up hyaluronidase for injection, we use bacteriostatic saline or normal saline. Water for injections can be used, but when injecting this solution with hyaluronidase, it can then cause a little bit of discomfort due to the change in pH that water for injections induces. Now, we use 3 different types of concentration, or I advocate 3 different types of concentration. Those are for the following indications. So first of all, I advocate a 150 unit per mil concentration of hyaluronidase for the treatment of fine nodules, small nodules, when we have to make small corrections to a treatment that we've already performed. Secondly, I tend to increase this concentration to 300 units per mil of hyaluronidase when I'm infiltrating hyaluronidase to effectively dissolve an entire area that we've corrected for a redo in the future. Finally, for urgent cases of vascular occlusion and ischemia, I advocate a use of 600 units per mil of hyaluronidase. And what I'm going to do now is explain a little bit of the rationale behind the use of these concentrations. So in order to decide the doses of hyaluronidase to use, we have to think about 3 things. First of all, we have to think about the volume of dermal filler that was used, that we need to dissolve. We also need to think a little bit about the degree of cross-linking of that filler as well, and the amount or concentration of cross-linked hyaluronic acid within that filler. This is going to affect the amount of hyaluronidase required to dissolve the filler, as well as the overall volume, which will obviously require more hyaluronidase to dissolve a larger volume. Secondly, we have to think about speed of action. If we are correcting something for aesthetic purposes, or we are correcting for a potential redo in the future, then there is no drastic urgency to perform a rapid correction here. We are quite happy to inject a sufficient volume of sufficient dose of hyaluronidase, and wait for it to do its thing and come back to it a few days later, or if it's a redo of the procedure, perhaps a couple of weeks later. If this is an emergency situation, however, we need rapid action and hydrolysis of the hyaluronic acid. Otherwise, the longer tissues are ischemic, the more potential damage to the tissue can be done, and the greater the amount of irreversible tissue damage at the end of the process. So we want to avoid this at all costs, and the quicker the dissolving or hydrolysis of the dermal filler in question, the better the chances of full, uncomplicated recovery for the patient. So in order to achieve that, the rationale here is a much higher dose should be used in order to make sure that urgent correction is completed quickly. Finally, we have to have a look at the area that we're treating, or the volume of tissue that needs to be corrected. So if we're dosing for a large treatment area such as the cheek, that is going to require a much larger dose of hyaluronidase versus a small nodule on the lip. So tissue volume requiring correction is essential in order to calculate the dose as well. Now, there are things to consider in terms of safe usage of hyaluronidase as well. It has been postulated that from in vivo studies that hyaluronidase denatures native hyaluronic acid in the skin. This is something that we have known about since the 50s, since studies were performed by Hector et al. Back in 1948 regarding how long it took to reconstitute the dermal barrier following a hyaluronidase injection. The important thing here is that in Hector's study, there was obviously denaturing of the hyaluronic acid dermal barrier. However, it took a few days before it was completely reconstituted. So even though a hyaluronidase injection may well cause damage to native hyaluronic acid, this hyaluronic acid is repleted or reconstituted within a few days. So whether or not this is a critical worry in treatment of complications remains to be seen. Certainly in my own personal experience, I've never had a hyaluronic acid correction where I've used hyaluronidase result in permanent loss of volume or deformity in the tissue following the correction. And this is based over perhaps in the order of 50 hyaluronidase uses over the lifetime of my practice. The other thing to consider is that some in vitro studies have shown that high doses of hyaluronidase can affect viability of dermal fibroblasts. If that is the case, then if this was to be an in vivo problem as well, then high doses of hyaluronidase may compromise skin healing following a procedure, and that's certainly something we don't want. The only thing I can say regarding this is that, again, in practice, in my own clinical practice, that certainly tissue viability following hyaluronidase injection is something that I've not really, or lack of tissue viability after hyaluronidase injection is not something that I've really seen. It's interesting. Claudio De Lorenzi wrote in his 2014 paper on treatment of complications that these concepts were indeed nebulous. I tend to agree with him because there's not really much evidence to support common occurrences of tissue deformities following hyaluronidase injections, and with the advent of dermal fillers, hyaluronidase injections have indeed become relatively commonplace worldwide. So yes, we need to take these things into account, but obviously we have to look at them with a degree of proportionality. So with those things borne in mind, yes, these worries about native hyaluronic acid and tissue deformity following hyaluronidase injection dermal fibroblast viability following hyaluronidase injection. I guess the proportionality that I'm talking about is for non-urgent cases. To be on the safe side, let's stick with relatively lower volumes or lower doses of hyaluronidase, and let's only think about high concentrations or high doses of hyaluronidase when we're thinking about urgent correction. So with regards to low hyaluronidase dosing for non-urgent correction, there was some good work done by Casabona et al. And published in the fourth edition of Soft Tissue Augmentation by Carruthers and Carruthers in 2017. And this shows that it is sufficient to inject between 4 and 28 units of hyaluronidase for most well-known brands of filler for a filler volume of 0.1 mils. So effectively, they're saying inject anywhere between 4 to 28 units to dissolve 0.1 mils of hyaluronic acid filler, and this varies depending on brand and also the type of hyaluronidase used. So in practice, I translate this to, in non-urgent corrections, using roughly about 15 units for 0.1 mils of hyaluronic acid to be removed. I then upscale this to 30 units per 0.1 mils of hyaluronic acid to be removed when I'm thinking about a more comprehensive dissolving of an area of filler that I intend to redo. Now, the reason behind this is, one might say, well, why not repeat the doses if you haven't completely dissolved at intervals? For example, if you perform the first dissolving, if you find that after a few days it hasn't been complete, repeat the dose. Well, this is all very well, but it also increases exposure to something that could potentially sensitize the patient. So repeated exposure of purified ovine testicular hyaluronidase could well result in sensitization of the patient to that product. So if I am going to dissolve, my preference when it comes to dissolving an entire area of filler for a redo will be to try and make sure that I do that in one single episode.